And this is kind of a sad slide. This is what the circumstances surrounding the overdose death was. And the take-home point is that 66% of the drug overdoses had some sort of potential for intervention. And also, my takeaway is that only 6% actually had access to treatment, which is really painful. A lot of them had a witness or a bystander. And also, what I think is pertinent to the ED is that actually 11% had a prior overdose and probably interacted with an emergency medicine physician at some point. And also, the release from institutional setting is release from jail, and that's also a point where you could have connected them with care, but maybe that happened or didn't happen. And my next slide is just kind of which communities that this has hit, basically. The non-Hispanic American Indian Alaska Native has been the hardest hit with a pretty significant drop in life expectancy, so minus 6.6 years. And I think this kind of overlaps with so many different intersections where this population tends to live further away from accessing healthcare, further away from metropolitans. And COVID hit really hard in these communities. So this is not just drug death. This is just all over death between 2019 and 2021. And I know from typically non-Hispanic Asians just have lower drug use all over if you look at different populations in the US using drugs in the first place. And they also have a pretty high just cultural tolerance to wearing masks in a public place, so that they also were not as hard hit by COVID. So I think that also plays a part. But still, substance use definitely pulling the number over at the non-Hispanic American Indian and Alaska Native. So when I see patients in the ED, really, the people that I have substance use as a potential differential is so many different complaints. All of these are situations where I'm thinking, couldn't this maybe be substance related? And a lot of people don't check in telling you that they're using a drug because they're scared of the consequences that that's going to result in. They're going to do a drug screen. What if they tell on me? Things like that. So people will come in and they'll have nausea, vomiting, and diarrhea. And then after a long time, you're like, oh, okay. Like you haven't used fentanyl in a day and you're feeling like crap. Okay, perfect. Well, it would have been great if you told me that up front because I could have given you something better, but I'm happy you told me now. And for sure, do not ever underestimate pain, chest pain and fever, or back pain and fever in patients with substance use, because that will be, for sure, either endocarditis or like an epidural abscess. And without the history of intravenous drug use, like, I don't know, we see back pains all the time, right? Like, just for so many back pains and chest pains too. And mostly what I honestly see is just pain. So increase in pain is the huge component in any kind of withdrawal. Even like my meth users are complain of just increased chronic pain. Whatever pain they have, it gets worse, and it's very intimately connected with withdrawing. And there is, at least in my colleagues in the US, kind of a resistance towards treating that pain. Especially with opioids, if that is their drug of choice. But I really want to push for a plug that this pain is such a huge trigger to use. So if you don't treat it and treat it whatever you need it to treat it with, people are going to leave your ED to treat their pain themselves because it's a part of their withdrawals. Yeah, that's pretty much all I'm going to say with that slide. So, what is addiction? I guess we need to have the like mandatory expose through some busy picture with, you know, all of these things. It's kind of helpful if you're a visual learner. It's when I think of addiction, I think about it as euphoria that leads to neuronal adaptation, that leads to using the drug just to feel normal and thank you, Arrow, for jumping, that leads to compulsive drug seeking to just function. Not even to have fun, not to feel good, just to function. And addiction alters the brain's reward and motivation and memory. So that leads to a cognitive failure. Kind of like how I think about heart failure or kidney failure, right? Like heart failure, you have exacerbations when you didn't take your meds or you fell into too much whatever food you shouldn't have been eating. And they come in and they need diuresis, they need admission, they need help. And I think of addiction the same way. The brain fails to meet what the body needs. The brain fails to keep the body safe and happy. And that's just a great model to put forward to just clear any sort of, moral issue, or like you just need to learn to do better or stuff like that. It is not a disorder of learning. And that's something I struggle with my colleagues at home to like figure out at least. So honestly, the best way that so this doesn't fly with my patients. They are like immediately checked out if I would show this to them. So what I tell my patients in terms of how to contextualize their substance use is that it's kind of like driving a stick shift or driving to work. Since I'm European, I drive a stick shift. No offense to all the other Americans who can't figure that out for themselves. But anyhow, you don't think about how you shift, you just drive, right? It's an automated behavior like anything else that is automated. And sometimes when I drive south on the 5 in Portland, I even take the exit to go over the bridge to my old work, which really sucks because you have to be in traffic for like 20 minutes to get back. And that's not always where I want to go, but it's like an automated behavior, right? I just like take that exit. And that's kind of like addiction, right? It takes a lot of dopamine for me to learn to shift and mistakenly take that turn, because going to work, honestly, is kind of minimal dopamine reward on that. But imagine like boosting that 1,000 times. That boosts the neuronal adaptation and the automatic behavior by 1,000 times. So people that use drugs, they kind of just have this blank stare and they're like, yeah, I guess I used again. And they can't really explain it. And you're just like, that's kind of a lame excuse. Like if you don't have a context for how quickly it becomes automatized like this, you don't really understand. You're like, well, I mean, how could you just do something that you're unaware of? But people can be truly unaware that they picked up like heroin or fentanyl or meth and smoked it or used it. They're like, I guess it happened. And with this analogy, I kind of have compassion for it. Like, I guess I drove the wrong way. Okay. It's not a big deal. And when I tell people that, they like really feel included. Like, this is a behavior that everyone does once in a while. Like, I don't know, you walk over and stare into your fridge and you're like, oh, this isn't exactly what I was supposed to do. Right. And us non-users do it too. It's just that for them, it's really harmful. Okay, that was a lot of talking. I'm already going off script, guys. And okay, so this is a super busy slide. Really only the thing I want to like impress upon this is how much percent of the basal release of drug or dopamine you get from certain amount of drugs. Morphine is there, of course. Nicotine is a player, but you see how the y-axis have different numbers, like they're not equal to each other. And amphetamine, it's like freaking insanely up there. So methamphetamine and amphetamine in general is just a substance that I have a huge respect for, and it's almost more harmful than opioids to some extent. And I'll kind of delve into what I think about that. And this is one of those, like, I don't know, you always have to include the landmark paper that changed everyone's view on something. So this is a paper from the best of publication years, 1988, that actually established that dopamine release and dose dependent, as the morphine scale is, is connected with addiction. Honestly, everything else for the DOPAC HVA, just don't think too hard about it. It's not a part of the point I'm trying to make. Okay, so this doesn't help us in the emergency department. This doesn't help me in my clinical practice. It's nice to know. So what is substance use disorder? Well, we use DSM-5 criteria to define it. Who has time to ask this many questions in the ED? Nobody, pretty much. So I've sort of boiled it down to 5 quick questions, which honestly covers all of the other 14, whatever it is. And it's all of these. If you've developed tolerance to the substance that you're using, you have to use more to feel the same way. If you've ever had withdrawals, and a good point is to actually ask them if they've ever stopped, because some people will say no, but it just means they have never considered stopping. And the other question is, have you tried to stop, but you couldn't? Also ask, have you ever tried to stop? Or has anyone in your circle of friends, family, anyone that cares for you asked you to stop because they're worried about you? Or any physiologic or psychologic damage from using substances? Do you think the reason you're here today has anything to do with the substance? Is a good question to ask. And I feel like that's a good non-judgmental way for them to kind of think about it before I speak my mind without their permission. And if it's a yes, I would really have thought through where you are in your practice setting to be equipped to offer any other answer than, the unsolicited advice to kind of stop it. And I would love to know more, like how referral pathways work here in Sweden, because I honestly don't really know that. And honestly, I don't really apply this. Like if somebody comes in for their 5th fentanyl overdose, like you don't even have to ask these questions. It's already a severe. You grade it from mild, moderate to severe, depending on how many yes answers on this really lengthy one. But it's kind of nice when you have a patient, maybe it's a little old lady, she's fallen over, she had 2 fractures in kind of a short amount of time. Maybe she had a positive alcohol level. It wasn't that high, but maybe it was high for her. Maybe she does drink daily. Maybe she also takes benzos, but you didn't check a tox screen or it didn't show positive. So for those more subtle cases, it's nice to kind of ask these questions and figure it out. Because I think even I miss a ton of patients in the emergency department that have substance use, and it probably just flies right by without me even identifying it. Okay, so what I do for my patients with substance use disorder in the ED. And this is going to first and foremost jump into opioid use disorder, because I would say 50% of my people is probably opioid use disorder. And I would say the other 25 is, or maybe 20 is alcohol and meth. And then the rest 10 is just like a mixed bag of God knows what. And honestly, you could boil this down to buprenorphine, refer for methadone. Alcohol, I prescribe naltrexone or acamprosate. And for stimulants, I have a really solid harm reduction talk. And that could have been like this entire talk in a sentence. I'm going to tell a little bit more about it. Okay, first case. So we have a 25-year-old male, chronic abdominal pain of unknown cause, severe opioid use disorder, using heroin for the past 6 years, who is presenting for evaluation. Had multiple overdoses in a recent past and a brief experience with methadone when touring in Australia, although stopped after 8 months, after being unable to continue the treatment in the US, and returned to using heroin. Multiple attempts to detox followed by abstinence-based sobriety with very little success, and who tried to use bupe really was successful, although lost access to treatment. And he states that his biggest barrier is to continue treatment when he goes on tour with this band. And this is a famous person, and whoever can guess who this person is, can get to choose one of my weird American candies that I brought to engage the crowd. Because who doesn't get engaged by, for instance, Sour Patch Kids and Junior Mints? I do. It all is going to go to me if you don't answer my questions. So you're going to have to help me out here. Okay. Oh, who am I? I already asked that. Okay, so this is an excerpt from this person's diary. It says, I bought a gun, but I chose drugs instead. I stayed on heroin until 1 month before Frances' due date. And you can just shout it out if you have a feeling. I checked into a detox center, and I went through 2 months of the slowest process I have ever witnessed in recovery. And it was 60 days of starvation and vomiting, hooked up to an IV pole, and moaning out loud with the worst stomach pain I've ever experienced. By the last 2 weeks, I was introduced to a medicine called buprenorphine. A little misspelled, that's okay. Which I found alleviates the pain within minutes. It's been used experimentally in a few detox centers for opioids, and this dates this a little bit, and for cocaine withdrawals. I bet this. Oh, the best thing about this is that there is no known side effects, and it acts like an opioid, but it doesn't get you high. I've been on an incrementally smaller dose of it for 9 months and haven't had a single stomach episode. Okay, any ideas? No. And you can ask me questions. Bring it on. He is dead. He's no longer with us. Yes, you got it. Kurt Cobain. And this is an excerpt from his diary from a book called Heavier Than Heaven by Charles Cross. Which candy would you like? Solid choice. The other ones are a little weird, huh? I did think about that to myself, and I was just like, you know what? If someone mentions that, I'm just gonna normalize people saying like, oh, I like need my coffee before I can function. I need a little treat in the afternoons to stay awake, because we all use substances to some extent. So anyhow, and this is really sad because like sometimes I feel like nothing has happened since then. This is the experience a lot of my patients share. Yeah. It's pretty profound. He was offered buprenorphine, which was still illegal to prescribe, but it was prescribed by a doctor called Robert Freeman. What happened after this diary note was written was that the DEA found out that he was prescribing this. They shot him down, they took his license, and he committed probably suicide. He was found dead because he himself, the doctor himself, was also using opioids and he's lost his career. So he died, and about a few months later, Kurt Cobain killed himself. He shot himself in the head. Okay, next one. So these are the kind of slides that I like. It's pretty simple. But still, my patients don't jive with this. So to make it even easier, I tell them that it's like methadone and naloxone had a baby together. And they seem to really like that. But yeah, this kind of tells you that this is a partial agonist. The half-life is 24 to 36 hours, which is kind of the reason why it doesn't get you high, like Kurt Cobain wrote in his diary. And the nice thing is that there is a ceiling effect on respiratory depression for opioid use, people that are used to opioids. How many of you guys have seen a patient in the ED on bupe? Yeah, oh, perfect, good, okay. I was worried this would like... Yeah, it's definitely out there, and I took the temperature on Subutex, Suboxone, buprenorphine on like flashback, and there is a lot of people trying to get their hands on it out there. So I would imagine you guys have all seen people who, with disclosure or not disclosing it, have it in their system. But really important to note is that the ceiling effect is not true for opioid naive people. Has anyone seen a buprenorphine overdose? Yeah. How did you guys manage this? How did they do? Oh, wow. So what I heard from you is that this person passed from their overdose. Okay. And we're going to go into a little bit more information about how buprenorphine can also be a really powerful drug because it is not well reversed with naloxone. And I have a slide on that later. But the number needed to treat is about 4 to 6 in people with opioid use disorder. And that's like amazing. Like aspirin after a stroke, the number needed to treat is 77. And we're like, I don't know, swearing by it. So I don't think it gets better than that. Can anyone think of a drug with a better number needed to treat? Yeah. 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 Let's see if maybe that's my next slide. No, it isn't, but we'll get to that in a second. I have also myself managed a bupe overdose, and it was like right before I started my addiction medicine fellowship in my little single coverage ED. An old lady took her husband's medication to treat her toothache, and she was out, like she was comatose, and I could not figure out how to figure this out, and because I didn't know the stuff I'm going to tell you at that point in time, and I just had this like spiral of like, I'm the worst doctor, I'm failing like both my chosen specialties. Hoped you guys didn't go through that. But she survived, and it was a lot of Narcan involved. This slide, it's just to get an idea of what dose is appropriate. So 16 milligrams and up, you have an adequate percentage of occupied opioid receptors. So 16 and up, you see retention in treatment. That's an appropriate dose. Some of my patients choose to have a lower dose, especially if they've been smoking a tiny bit of heroin, or used like prescription oxycodone, maybe more than they should, but not really in a crazy way. Then a lower dose is appropriate, especially also if they've been on bupe for like 20 years and slowly shaved off a milligram here and there. But all my patients using fentanyl, I give them bare minimum 24, sometimes even 32 as a Hail Mary. But as you can see, kind of plateaus around there. And there's not a whole lot more to win going beyond. All right, jumping into this. So this is, I know, a lot of numbers, but it breaks down pretty quickly because on our right here, we have a Ki constant, and the number, the lower the number, the stronger the binding to the opioid receptor. And that sucks to be naloxone because you can tell that buprenorphine binds much better to the opioid receptor, right? That's why we need to use so much Narcan to overcome that binding. We can also learn that sufentanil is a pretty good analgesic option for our patients on bupe, or honestly just really high dose anything. I like to use hydromorphone if I need to alleviate pain in my patient on buprenorphine, because it comes right under, so you don't need to up the dose that much. And also, like, fun fact, when I was researching this, I just like stumbled into so many weird papers, and one was like from Iran, where there is a lot of opium use and a fair amount of methadone use, and they had a methadone overdose in a very resource scarce setting where the Narcan drip was not an option, and they reversed it with buprenorphine instead because it is a one-time oral dose and it lasts for 24 hours. Not saying that that is by any, not gold standard of care, but it was just like a cool case report when they had to MacGyver something. Yeah. Oh, the other thing that we can learn. If we give buprenorphine to somebody who takes fentanyl daily, we will also cause withdrawal, right? Because the buprenorphine is going to replace whatever they're on, fentanyl, for instance. And because the receptor activity, it's just a partial agonist. So we're going to drop them down from a full agonist to a partial agonist. And the body feels that as a withdrawal. It's actually, you would think going from 100 to 60 would be better than Narcan, but it is not. I would say people are just as much suffering as you gave them Narcan. And with Narcan, you have only signed up for 20 minutes or so of suffering, but with buprenorphine, you've signed up for 24 hours. Like, it'll be a full ride, and you are going to have to apologize to that patient. And don't worry, like, I've done this plenty of times. You become great at treating symptoms and alleviate whatever pain you cause them by giving them the bupe too early. Well, this is a good slide, but I've seen enough of it now. Okay, so other question. This could be a candy question even. Why is there naloxone in Suboxone or in buprenorphine? Going back to our last slide, does this make sense? That's right. You're going to get a candy for that. But I have issues with, which one would you want? I think this is like underestimated. It's like peanutty inside. The Junior Mints, made famous by Seinfeld, is also a good option. Junior Mints. Okay, you're a mint kind of person. This is my favorite. Okay. Oh, sorry, I will repeat the answer to the question. So the question was, why is there naloxone added? And you told me that it is to deter from IV use. But if we quickly jump back here, like, if you use bupe, is the naloxone going to actually do something? No, right? It doesn't do anything. So it was something that was added by the company trying to push this forward, get it approved by the DEA real quickly. So they were like, oh yeah, what if people use it IV? What if people like misuse things? Like, You know, it's just very rife with stigma against this group because not like we add naloxone to morphine tablets, do we? No, we don't. To oxycodone, nope. Only for bupe. And I've had plenty of patients who had IV'd both Subutex, like the single monoproduct, and Suboxone, and they're like, yeah, it's no difference. Like, it's useless. What it does do, though, is that you have it, so you can't Narcan somebody in your mouth, right? We put it in the nose. So, because it doesn't absorb through the GI tract. You cannot save somebody by giving them Narcan orally, really. But it does, yeah, bring it on. Mm-hmm. Yeah. I think Targinic wasn't that to prevent constipation? Because they are actually aware that this is only going to stay in the GI tract. So this is a less stupid medication. So they're trying to keep the naloxone in the GI tract where it actually binds to opioid receptors. It causes nausea. A lot of my patients, even with alcohol use disorder, naltrexone is the first line oral medication. It causes nausea. The first 7 days, they hate it because it makes you nauseous. And for sensitive people, they sometimes can't even tolerate Suboxone, and I have to switch them to monoproduct. So it actually is an additive. It doesn't save you from anything, but it also does harm people. I've heard people who discontinued their treatment and went back to using heroin or fentanyl because they couldn't take the nausea. It reminds them of withdrawals, and anything that reminds you, it's kind of like a PTSD response. Anything that triggers memories of really bad withdrawals, it's really triggering for my patient population. So it doesn't make sense, but then when you think about it in a trauma sort of aware way, it does make sense. And that is the reason, like, that's what FDA have on their website. And that's actually what FAS also has on their website. I don't think that's very clever, but that's what's there. I don't think it's true. As proven by the paper with the KI constants and also by all my patients in real life who are like, yeah, the high is the same. Okay, case 2, fentanyl. The star of the show. Kind of stealing the thunder from all the other ones. 56-year-old female with over 20 years of severe opioid use disorder, mostly using heroin, presenting as a transfer to my emergency department for an MRI and neurosurgery consult. You can already tell this is a bunch of BS. For suspected epidural abscess. Patient has been smoking fentanyl for about a year. She couldn't access her heroin. No injection use for the past 7 months, and acute on chronic neck pain and a fever. So she showed up. She's already been in this other ER for like hours, done a myelogram, CT, sort of neither here nor there. She was in withdrawal. She had full-fledged withdrawal. Sweating, ready to like swing to get out of there. I gave her 8 milligrams of hydromorphone. I gave her 8 milligrams of morphine. I gave her 40 milligrams of methadone. I gave her 500 micrograms of fentanyl, which is a lot of millimorphine equivalents. I also gave her clonidine, olanzapine, ketorolac, and hydroxyzine. And the pharmacist like came out of her pharmacy, which she never does, and was just like, "What are you doing?" And the problem was, I like brought the pharmacist over. I'm like, no, this looks kind of sketchy, huh? But the patient was in full-fledged withdrawal. Like she was sweating, she was puking, she was miserable. And I just felt so embarrassed that I could not treat her pain. We ran out of we ran out of fentanyl, our fentanyl. And she was just like, you know what, I'm gonna go and use and I'll come back. And I was like, yeah, it's not exactly how it works, but you can definitely do that. And yeah, so the patient eloped. But at least I sent her with a prescription for meds. It's a hard job. So anyhow, my learning point with this is really just how potent the fentanyl is that is circulating in the US. She didn't even bother sticking with these blue pills. This is like what was around a couple of years ago, up until maybe a year ago. They make these fake oxycodone pills, and they look exactly the same. So a lot of people don't even realize that they've been smoking fentanyl. They think they've been buying like pharmacy grade oxycodone, but is not the same. And now, more recently, I really see that people like do just the powder. Like they didn't even bother to press it into pills when they sold it. This is kind of, has anyone started buprenorphine on anyone in the ED? Any takers? Okay, so it's really simple. Anyone can do it. It's kind of like following a recipe. if the patient is in enough withdrawal, according to the clinical opioid withdrawal scale, they can have buprenorphine. If not, they go home with a prescription. And this is kind of usually the workflow that I follow if people come in withdrawal. And the clinical opioid withdrawal scale, as you could imagine, is all the signs of opioid withdrawal, which we have on the right. I think I already said this. I got like excited before and already said this. But anyhow, naltrexone, acamprosate. I send people home with this for like a month. If they tell me like, yeah, I've been drinking for 20 years, I can't stop, I've never seen a doctor, I would love to try some medications. And usually in the ED, you've done a metabolic panel. So you have some liver enzymes and you can see if they are fit for naltrexone. If not, we have acamprosate with the most rock and roll dosing in medicine, which is cool. And for stimulant use disorder, as I said, I just kind of do a really great harm reduction talk. A lot of patients have really poor oral like hygiene status, meaning like they don't have teeth, which is largely due to for people using meth not having access to like water, drinking when they're thirsty because they get high and they go on benders where they get rhabdo and don't drink, but mostly because taking a stimulant makes your mouth dry. Probably about as dry as, you know, when you hold a talk and you need a little glass of water on the side. So yeah, that's I talk a lot about that and how to avoid that. And if I have time later, I'm going to talk a little bit about contingency management. And this is again just a reminder for the ED DSM-5, Ricky's like reversed version. Okay, so we've come to the point where I'm going to share some detox pearls and pitfalls, probably hard-learned truths that most of my learning is from mistakes, so we're just going to do it. So kratom is super popular. Anyone heard about it here? Yeah. Is people showing up with this? Like they buy it, take it, use it? Yeah. So it's pretty common in the US. It's legal. It is originally grown and used in Southeast Asia, where it is used as a tea. Traditionally for like manual laborers who work out in the sun and sweat and work hard. And this is, I think the plant is like related to coffee or tea or something like that. So mitagenin is the alkaloid that is the agonist for a bunch of things, which is kind of a problem. U and delta opioid, alpha adrenergic, dopamine receptors, and serotonin receptors. The one with stars is really what I see as the withdrawal kind of complex. So it's opioid withdrawals, but I also feel like it's sort of like abruptly stopping your SSRIs. Like people have this weird like zaps in their body and really, really high anxiety level. And usually they stabilize really well on a low dose of buprenorphine, somewhere between 6 to 12 milligrams. And I also offer them an SSRI, like some sort of antidepressant to help with the serotonin receptor loss of agonism, I guess you can say. Deaths have been reported, but it's kind of a gross powder. Like you have to eat a lot of powder and it tastes like grinded up grass, they tell me. So at least that's a little bit of a barrier, and people use it a lot in lack of healthcare, in lack of buprenorphine, in lack of a doctor. They try to taper themselves off of stronger opioids using this, and then they end up not being able to stop because kratom, straight from the plant, isn't very strong. It's like a band-aid on your withdrawals, but the stuff sold in the stores are strong, like it's concentrated. So people end up using probably the same amount of drugs that they used before, but now it's just in a green powder or something. DMX or dextromethorphan. Anyone familiar with this substance? Yeah, it's kind of a lame substance, honestly. It's fortunately also, an over-the-counter cough medicine in the US with a dissociative effect in high doses. So people not having access to more fun things, they go and buy cough syrup. It's kind of like a poor man's ketamine. It is called Skittles or robo-tripping because people have this like zombie robot-like gait from it. And it's a mess in terms of its activities. It's a sigma opioid receptor agonist, which we think, but we don't really know, is probably what helps with the cough, but also what causes respiratory depression. Thankfully reversed with naloxone. And the other mechanism it has is that it is an NMDA antagonist, great with downstream glutamatergic, serotonergic, and cholinergic effects. So people get pretty messed up on this. Also, thanks to like the fact that all medications in the US are mixed for your convenience, is that it's a ton of like Tylenol, meaning paracetamol, some sort of H1 blocker, diphenhydramine to make you tired. So it's always a mixed kind of overdose type of picture, and also not uncommon in honestly suicide attempts. The lines are blurred between fun and not fun. But still though, step forward. I'm happy we don't have this available in the time of right now. And another one who's like just kind of notable mentions is xylazine. Anyone heard about it? Yeah, what have you heard? Oh, very cool. Yeah, okay. Yeah, I love it. That's exactly kind of what it is. Well, I guess it's closer related to Precedex, dexmedetomidine, and clonidine. I plug those little guys in there for whoever likes to see that to contextualize their drugs. So this is a weird one. It's actually a peripheral and central alpha 2 agonist, and kind of like an opioid chameleon. And the reason why I've just plugged it into the opioid-esque group is that it is a really common adulterant in the fentanyl and heroin supply in the US. First noticed in Puerto Rico and Philadelphia, and it was added to cut the drug with something cheap to prolong the euphoric effect and to stave off withdrawal from fentanyl by a little bit of sedation. The problem is that a little bit of sedation with downers and downers are never 1 plus 1 is 2. It's a lot. So 37% of fatal opioid overdoses were positive for xylazine in Philadelphia in 2021. And you cannot reverse this with Narcan. And it also causes really terrible skin necrosis from vascular constriction. I would say it's up there with like the Russian drug crocodile. It causes like chunks of skin to fall off. It's terrible because, and I can't really wrap my head around this because I'm, just a doctor, but the alpha 2 agonism somehow in the periphery constricts your arteries, but centrally in your brain, the agonism leads to blockage of norepinephrine release, which causes sedation. And this sedation can like last for hours. Some xylazine overdoses that we saw were just like comatose for 8 hours plus. Weird. And all of the symptoms around my really cool stick figure that I made also happen. So you can definitely get cardiovascular collapse from this, and there isn't really a whole lot of reversal. Okay. All right, sedatives. That's fun. I feel like, honestly, I haven't really made a slide on alcohol because it's sort of the national drug of choice. And I feel like everyone here has probably handled opioid or alcohol withdrawals, or you will, right? Did I get that right? Did I get the temperature right on that? Okay, cool. Okay, so why do we, question time, because I think you guys kind of know this. Why do we use just lorazepam and oxazepam to our alcohol withdrawal peeps? Why is that preferred? Pew, pew. Yeah, go. They do, but so does, I don't know, the other ones, alprazolam or clonazepam. Yeah, I like that. And what makes it like stay in the blood? You're like very close to candy right now. What decides if it like is a reliable level in your blood, and what does alcohol really burn out in the body? Good, but it doesn't affect the drug level. Who lives in your right upper quadrant? Yes. So, which candy do you want? Because I can't like I don't want to eat more candy. The yellow one, the Sour Patch Kids, or the peanut buttery one? Solid choice. I hope I'm not gonna do this. Okay, so you're really close. The actual reason is because okay, I'm probably going to butcher this, because all the other benzos requires both the liver to oxidate and do the glucuronidation. So that's much more unreliable in our patients with liver failure. So when we get a really sick person and they're about to seize from their alcohol use disorder, you don't have time to like check liver enzymes or look at their liver or whatever. You need to give them something that they will reliably metabolize, because if they have this much liver left and you gave them alprazolam, they are not going to reliably get that into their blood after the first pass metabolism. Or also, if you give it IV, it still isn't, a lot of the other ones have active metabolites, like it has to be metabolized to something to be active. And lorazepam and oxazepam is like the least effort for the liver and the most reliable level to avoid over-sedation. Because, I don't know, oh my gosh, alcohol withdrawal is like its own talk. But we've all been there who like, oh my gosh, you're going to have a seizure, I'm going to give you a lot. And then you give them like what you think is appropriate, and they sleep for hours because the liver doesn't reliably metabolize it, and that's a huge problem. Yeah, that's at least a part of our CWA protocols. And when I did detox, we just carried oxazepam because there was some sort of Ativan shortage, so I became pretty comfortable with it. But in the ED, I feel like the nurses and me too are more comfortable with how lorazepam hits and works. Anyhow, so question? No. How often do you guys use phenobarb for alcohol withdrawal? Not at all? Okay. I depends on the setting, but if I have a super busy weight room and I know that somebody is like not in the resus bay who should be in the resus bay, if I know I gave them like a slug of Ativan, 4, which should put them to sleep, and they're still sweating, I give the lowest dose oral phenobarb, just a weird dose, like 67.5 milligrams or something like that, because that's kind of nice. I think I have a picture of that. Also, another pearl in alcohol use disorder, I feel like I've gotten at least 2 sign-ups from a colleague who are like, oh, this person just needs to go detox. And when I go and order, I add some labs and I'm like, okay, well, the liver enzymes aren't that crazy. But when I add an INR, the INR is disastrous. And that is really the true marker of liver function, because if your liver is this big, it's not going to make a whole lot of liver enzymes. Those are going to be falsely down. So those are not reliable. They're great for acute liver injury with like a Tylenol overdose in a healthy person. But for our long-term alcohol use disorder, is not your best friend. INR is. And MELD score, kind of think about, do they need a liver transplant? Are they going to die from this today? Or can we like make sense of this in my ICU where I don't need to transfer, where I don't have gastroenterology or any really advanced surgery? And this is just like, I don't know, don't like these receptor pictures, but I just wanted to show where the benzodiazepine comes into play and how the barbiturates actually act on a different part of the receptor, which is great because at about 20 milligrams of lorazepam, I'm done. Like I've saturated all my benzo sites. Giving 30 is going to do nothing, right? So that's when we need something else on board. Barbiturates are nice because you can give a low oral dose right up front and maybe avoid disaster down the line. Also, alprazolam, I don't talk about it a lot, but I don't like it because it's the highest risk for misuse, for addiction, because it's so fast on. And I see a lot of issues with benzos in my patient population. It's so easy to buy, like literally a couple of clicks away, and you'll get it shipped to your home. The new versions of benzos that people come up with are outrageous. And there's like a new one on the street every other month or so. They like make one illegal and they come up with a new one type of thing. So anyhow, yeah. Okay, I'm going to leave alcohol be for a second. And that's another problem. How well does what sort of detection urine screen do you have for benzos? What does it pick up? What does it not pick up? That was really just a question so I could drink water. Yeah. Okay, there's no point. Yeah, I'm right there with you. I just assume that it's probably all up in there. But I think it's good to, or I don't know. I just like to spread the word that patients or other practitioners might draw the conclusion a negative benzo screen because we don't even detect the stuff that we prescribe, like alprazolam and lorazepam in a therapeutic dose will not turn my urine screen positive. And definitely not the illicit ones. They're like, forget about it. But it is the most frequent drug associated in opioid overdose. And that's why I kind of fear it and want to talk about it with my patients. Oh, yeah. Then we have our GABA B agonists. Phenibut. Anyone heard? A little bit closer to Russia here. Okay. So this has been like sold as some sort of cosmonaut drug. They developed it in Russia for nervous space travelers. Right? That sounds fun, right? That sounds like something I would order on the internet. Not really, but like I understand that that selling point does sound kind of adventurous. It's actually a little bit of GABA A, but mostly GABA B activity. And I also unfortunately have dopaminergic activity and some sort of nootropic activity, meaning it focuses your mind and enhances performance. I like fell into poorly translated Russian papers from the 80s and gave up on understanding how that would really work. I'm not even sure if that is true, but they claim that to be a thing. And withdrawal from this, I actually saw this quite a lot in my detox. Similar to benzo, alcohol withdrawals, and a few like severe, like needing ICU level of care has been reported, but otherwise pretty well managed with benzos. GHB, anyone see that here? Oh, weird. Okay. I don't have a whole lot of that in the US. I've actually not seen a single patient in my whole year of addiction medicine fellowship who told me that they were using this. So maybe I can learn something for you guys. But I do know that the intoxication is pretty classic for like a coma and a really abrupt awakening. They'll just like wake up, pull their tube out, and be like, guys, thank you, but I'm out. And the withdrawals are similar to benzos with a little accent of agitation and psychosis and possibly some aggression. And it's a weird one. I didn't even know that we have GHB receptors that directly interacts with this substance, and that it also releases growth hormone. But it all makes sense now because it's usually like a bodybuilder type of thing. And this is just sort of structurally how they look for, again, our visual learners. And the next page I dedicated to the baclofen. Not that it is really a substance of use. I haven't seen any patient misuse it, but it's your only GABA B alternative that can be given or prescribed. And it is actually quite commonly given to patients with spasticity. Anyone seen a patient with a baclofen pump? Yeah. And I feel like this is one of those things that at some point gonna pull you aside and humble you because it is a really dangerous thing when that malfunctions. So the reason for the intrathecal pump, as you could imagine, is that oral baclofen doesn't really penetrate the blood-brain barrier very well. If you have a patient with baclofen pump failure, benzos are first line because oral doesn't really make sense, but also neurosurgery to fix the pump is probably first priority. The scary thing with baclofen is that the withdrawal causes fever. And in this patient population that have a baclofen pump, a lot of them are like chronic neurologic damage, like they're paraplegic, quadriplegic. They might not be able to communicate that they have this, right? And if you don't do an x-ray or a CT of their stomach, if you have pneumonia on the chest and they have a fever and they're starting to get a little spastic and kind of muscle stiffness and maybe a seizure, you're like, well, you have a lot of, neurological injury from cerebral palsy or whatever, and it can be missed. So it's just one of those kind of pearls for non-drugs of misuse. And yeah, stimulants or the lack thereof. I think I'm gonna slide in right on time. So methamphetamine, I feel like it doesn't get enough attention. It's such a dangerous drug. Overdose doesn't really kill you that often. You get hypertension, you get tachycardia, you get psychosis, these characteristic body movements, insomnia, lack of appetite, thirst, delusions, aggression. and the substance is addictive fast, right? We saw the peak was like up in the thousands on the dopamine scale before. And honestly, the sad thing is that most of my patients use this substance to just function. Before I started fellowship, I was like, meth, like why? It seems like a miserable substance. But the more I talk to people, the more I understand that it is to cope with a reality that just really sucks, right? Like if you're gonna work 3 jobs and collect cans, or just be homeless and it's dangerous to sleep at night, you'll be murdered, raped, or people will take your stuff if you fall asleep. So people use this to just survive. And also, what I hear a lot is that people use it to treat pain. I don't understand how that would actually work, but so many of my patients say it, so I'm sure it's true. And I think it's just a vastly underrepresented cause of death because you don't show up and you die from it right then and there. But over time, my patients die from lung injury, like COPD, that's so bad because people kind of hot rod it, which means that you light up a piece of metal and you smoke it in that piece of metal, which kind of fries your lungs. People develop pulmonary hypertension. People will just, I don't know, just wear out your body. And cardiovascular, we're not even going to mention it. So it's really a complex drug with underrepresented sort of death numbers on it. Also, the fact that people don't even have to pay money for it in the States. Like I asked them, like, well, could maybe saving some money be a reason for you to motivate you to stop? And they're like, I haven't paid for it in years. People just give it to me. So it's so prevalent. And it's honestly, I mean, it's cheaper than a warm clothing and a meal. So it's just there. And this is one of those pictures again. But really what I'm trying to say is that the meth, the yellow dots, gets its way inside the cell. It's block reuptake. It opens up the channel so the dopamine escapes and it stimulates to release the dopamine. It does everything to get dopamine in the synaptic cleft. Okay, last question. Okay, good. I have 1 left. 2 left. Which one is for meth and which one's for crack? Do you all know? You can also guess because it's a 50-50. Crack, the one with the ball on it? No. So meth actually has a fluid face where you can't smoke it in a straight stem. So it turns into a fluid and you have to have sort of a collection cup to smoke it. But crack you can put in that little brass gauze and just heat it and smoke it. Candy for me. Okay. I think we can squeeze this last one in 1 minute because it's kind of weird and it's also a medication that actually exists here in Sweden, not covered by Läkemedelsförsäkringen, but yet still. It's a weight loss drug, and I've seen a lot of women particularly get stuck on this. They buy some cheap drugs on the internet, and they start to take phentermine. It used to be a predecessor of this is phentermine, fenfluramine, which caused pulmonary hypertension in 30% of the cases, which is really sad because I wouldn't wish that on my worst enemy. There's been like a 1-year randomized controlled trial on the phentermine single component. And it told us it was safe, but I don't know. And also there are other drugs on the market with a better safety profile, so I don't really know because phentermine is pretty much analogous to methamphetamine. But in the prescribed doses, the lower doses, it's mostly predominantly norepinephrine and less dopamine. But when you buy it on the internet and you take how much you want, it is really just methamphetamine. And yeah, I've just seen so many patients get stuck on it and need inpatient detox. Like, I don't know, stay-at-home wives, mother of 3 who like just bought it and used it. And I think it's likely available here in Sweden too, because it's easy to buy. Yeah, and the one available in Sweden is the Cusiva, some sort of phentermine to pyramate mashup. And then I'm actually at the hour. I have like 2 more slides, but we're going to be cognizant of the next person in line. So if you want to hear more about bupropion, hallucinogens, or any of all the very ambitious lists I showed you at the beginning, you can ask me about it later. Does anyone have a last comment on what you guys think that you could do for patients in your emergency department? Or something that you're already doing, you think you do it quite well? Question was use olanzapine together with benzos. Um, Good question. I find that these antipsychotic olanzapine can cause sort of additive sedation, so I try not to, or at least I give them far apart from each other. So it depends on if I think they need a benzo right now, I give that, and then I save the olanzapine for maybe a couple of hours later to not stagger the sedation, because the two of them can be a little tedious. But like sometimes I do if they need it. Any other questions? Yeah, bring it on. Yeah. Mm-hmm. Yeah, thank you. And thank you for coming. I would love to hear more about how things work in Sweden because I'm really curious. I'll save that for later tonight. Thanks.